Office for the Advancement of Telehealth and the Southwest Telehealth Resource. My name is Megan. For those of you I don't know, I am the Executive Director, very proud to be the Executive Director of the New Mexico Association for Home and Hospice Care. And I'm pleased and grateful to AXXESS for their sponsorship today, and am pleased to be introducing Betty Singleton. She is the Vice President of Regional Sales at AXXESS.
Hello, everyone. My name is Betty Singleton. Thank you for that, Megan. Can you guys hear me okay? Perfect. I would like to say welcome to the event on today. We're excited to be a sponsorship for the event. AXXESS, as we all know it, is an entire suite of solution for everyone to utilize in the industry. We take pride in our educational and the solutions that we offer to you, which is home health, home care, hospice, and many others. We try to give you the entire suite so that you're not seeking other solutions outside of AXXESS suite of solutions. Today, I will be introducing Miss Arlene Maxim, who will be one of your speakers. Arlene Maxim has more than 40 years of nursing experience. Arlene is a sought out speaker in many areas of patient care, including quality analysis and administrative functions in post-acute healthcare. Co-founded regional multi-million-dollar Medicare certified home health care companies, hospital-based home care and hospice companies, and transitional care programs. Arlene is the board member and vice chair for the Association for Home Care and Hospice Coding and Compliance in Maryland. She is a clinical consultant for AXXESS, today's sponsor. Currently, Arlene leads innovative change across the healthcare continuum. She has developed and implemented multiple post-acute care programs, working closely with multiple hospitals, home care, and hospice agencies, accountable care organizations, etc. Arlene's energy, dedication, and passion continue to positively change the post-acute world of healthcare. So without further ado, I'm going to say welcome, Arlene, and we're proud to have you here.
Well, thank you so much, Betty, for that introduction. I just want to start out by saying, if any of you caught that 40 years of experience, I started when I was 6 months old. So you want to count backwards, you can figure out how old I am. I really am taken aback when I hear that number. I'm thinking, oh my goodness, that's almost when Medicare actually started in 1965. So it's been a long time. I've been through about everything anyone can go through in the program, all the changes that Medicare has had and that type of thing. So I'm really excited about today's presentation. I want to take a couple minutes just to talk to you personally as a nurse, though, and as a home care nurse and a hospice nurse. I want to have you, as you go through these slides today, think about what you can do in your organization with technology to actually make it work for you. Technology has been around a very long time, and those of you who've heard me speak in the past have probably heard me say that I don't really agree with technology as far as patient interaction and that type of thing. It has come such a long way in the past few years, and certainly since COVID-19 has hit and CMS has been recognizing the importance of the technology and telehealth. I was talking to someone, just so that you know this, I was talking to someone a couple weeks ago, and he was telling me that the physician groups that he was working for have been using remote care technology now since COVID started. They billed out $90 million. This is a group of like 10 physicians. Now, that should tell you that this is gaining quite a bit of interest in the community, in the healthcare community. And in home care and hospice, it seems to me that we sometimes get behind, we're a little skeptical, actually a lot skeptical about a number of things that happen and changes that come up in our healthcare arena. And we don't necessarily latch on to things as quickly as others. Now, I'm really surprised that the doctors did. However, physicians get paid. And as we talk through today in this presentation, we will talk about how home care and hospice is a little bit different, but in home care, we don't get paid for the use of tech. However, it can save us so much money in the end that you really need to take a look at this with your accountants and your owners and whoever else is involved in your budgeting, and take a look at this and see what it can do to help you not only save money, but improve your patient outcomes. And that's what we're going to talk about today too, because it's absolutely a definite improvement to patient outcomes and the retention of staff. And we're going to talk a lot today about the shortages of staff. Now we've got Medicare, and I don't know if you've all read this, but Medicare just came out a couple weeks ago with the details on hospital care at home. And with that, we are going to see an awful lot of hospitals reaching out to home care agencies, wanting to maybe have contractual relationships with them, those with telehealth and having telehealth experience and have a way to monitor patients at home are likely going to go to the head of the class with this, because the hospitals are going to want to be able to take some part in the care of their patients at home with this program. So I can see telehealth and remote care monitoring just really exploding over the next 6 months to a year. And I'm guessing, and I'm pretty good at guessing what CMS is going to do, but I'm guessing that we're going to see CMS actually come out and start paying us for some of this monitoring. I know that NOC and I know some of your state associations are working really hard and pushing this. They're actually trying to get the remote care visits paid just as a visit. Right now it is not. In hospice, since you're paid differently, the hospice billing could include the telemonitoring. So you would be able to use that on your cost report. So we'll go to the first slide, please. Okay. So today, our objectives today, although I just got done with a few of them, we're going to talk about how technology is such an important part of the healthcare success and your staff retention. And you're going to see that. I'm going to show you some statistics on the staff that are actually leaving because of retirement and that type of thing, and some information on the number of patients that we have that are increasing every single day with the baby boomers turning 65. And so we have so many opportunities, and those folks in that age group are much more familiar with telehealth. They've had televisions around since they were children. So they got used to using the remote. There's all kinds of different things that, as far as technology is concerned, that they've gotten used to. So the seniors that we are currently seeing that probably were the World War II veterans and their families are going to be moving out, unfortunately. And then, so the folks that do have that but technology experience will be moving into our arena. And so they'll be much more familiar with this. So we're also going to explore some ideas on how to promote technology to improve patient outcomes. And part of the problem I've seen in dealing with the remote care monitoring, and I'm going to talk a little bit about my personal experiences with that, but part of what I've seen is nurses' reluctance. And as I mentioned earlier, I think that just home care in general, we are very skeptical about so many things. And so the nurses many times are the holdback in using the technology. I know I was at a very large agency a year ago, and they told me that they had like 25 units that were sitting on a shelf because the nurses didn't want to use them. And I think that part of it is, if you choose to go into remote care monitoring and use telehealth in your organization, it's really going to be important for you to take a lot of time to train your staff and to promote the use of technology as we go into this new experience in home health and hospice. Next slide, please. Okay, so 1 in 5 Americans are going to be seniors by the year of 2030. So that's coming up faster than I would like to see it. We're already in 2021, and we are again seeing that the senior population is rising every single day. 88.5 million people will be 65 by 2060. And then expenditures actually last year were $4 trillion just in healthcare. So anything that we can do to help the silver tide that we are experiencing right now in reducing the cost is going to be very, very beneficial. And CMS is seeing the advantages that telehealth is having on reduction of cost and the improvement in outcomes of the patients right now. We're already seeing statistics about the decreased length of stay in the hospital, the decreased readmissions to the hospital. And all of those are going to be, of course, part of what we'll see with value-based purchasing, that they are going to probably expedite pretty quickly. We're not going to see many more years of the trials that they're working on right now. We're going to see that value-based purchasing is going to spread over the US probably in the next year or two. Next slide, please. Okay, so this is just a graph on showing the age, and so you can see how quickly those numbers are going up. And right now we're kind of like on the upswing of that. So we have to get ready for what's to come. And we have not only a shortage of nurses now, but we have a shortage of into nursing. And so that's a difficult one to overcome. So part of our job as nurses is probably to be encouraging our children and our grandchildren to get out there and become nurses. I actually have 3 nurse practitioners in my family and 2 with doctorates. So I'm really proud of that. So at least I've done my part to encourage the nursing profession. So, so I encourage all of you to do the same thing. Next slide, please. So why telehealth and advanced care? Of course, again, the average age of the nurse right now is over 50. So there's an estimated 70,000 nurses that are going to retire annually. And then just keeping up with those numbers that I just showed you is going to be very, very, very difficult for us. The older nurses, and here's something, a phenomenon that's happening. You've probably seen it in your organizations. Well, over the past year, the nurses over 50, of course, I think they're saying 65, 75 and over are the ones that are more likely to come up with COVID, but those nurses over 50 are concerned. And so they are the ones many times who are not willing to go out and expose themselves to COVID. So I would, that's something you need to take into consideration. And I've heard from a number of agencies that several nurses are calling in and saying they don't want to see COVID patients. They don't want to be exposed to it. So we've had a real struggle, which is one way telehealth can really help in at least monitoring your patients. We do have PDGM with Homecare that started last year, and we were really concerned about getting our visits down and monitoring our visits. Well, we didn't really have to be too concerned about that because we didn't know that COVID was coming around, and that just kind of shrunk our number of visits pretty quickly. We didn't have to worry so much about having to do it. It did it itself. So just keeping up with the aging population, the newer nurses are coming in, are either fresh out of school, and which is, I think, a problem, or they've worked in hospitals and they haven't developed the interpersonal skills necessarily that you need to have when you go into home care. So it's a whole different environment that we're in. We're working with millennials that have different work ethics than those of us who have been in the business for a while have. Not necessarily staying power. They don't stay in jobs very long. So having the average age of a nurse over 50 is a problem right now. And it adds to the nursing shortage we've seen over the past 10 to 15 years. Next slide, please. So the average tenure of the nurse is 19 months right now. So most nurses are, and that's in all types of nursing. So the commitment to one place isn't there like it used to be. Again, telemonitoring, telehealth is a way to entice some of these younger nurses. They, like I said earlier, these younger folks are more into technology. Part of their training is in technology. Of course, AXXESS has technology that is just unbelievable to me as far as an EMR is concerned. So the nurses that are coming out of hospitals, coming into home care are more familiar with technology, but not the type of technology that we need to use in home health and in hospice. and certainly not the type of patient evaluations that we need to do in those two entities. So there's a little bit of training that needs to be done. But I also have found in the number of years that I've been working that part of the reason nurses turn over is they feel, number one, they feel stressed. Number two, they feel like they're working too hard. They're working late at night. They're not using the technology the way it's supposed to be used. The electronic medical record, of course, was a point of care system. And what we found is it's a point of kitchen, it's a point of airport, it's a point of everything else but point of care. So they're not using the technology the way it's supposed to be used. They are waiting to get home. They're taking notes. And by the way, those notes you take in your little notebook are not HIPAA compliant. So keep that in mind. I hadn't thought about until a couple of years ago when I was listening to an attorney speak, and he mentioned that, and I thought, gosh, I never even thought about that. Those notes are not HIPAA compliant. So that's something to remember and to teach your staff. That should be part of your orientation process. A big part of it is they feel like they don't have the training that's needed. They don't have the orientation. So a good portion of your orientation should focus on the importance of technology and how important it is that we use it the correct way. And we use it to reduce their workload. Sometimes people think they know why they need to be doing things and they don't necessarily know. So making sure you have a very concise orientation program and that it's filled with information that's important, not nonsensical information. We're going to talk a little bit about times we're going to have to really discuss infection control right now with COVID-19. That's a big thing. But with telehealth and with telemonitoring, you can do a lot of those infection control procedures without going into the home and prior to entering a home to decrease any anxiety that nurses may have about being infected. The next slide, please. So the average cost of turnover, and this is something important to remember, ranges from $37,000 to $58,000 a nurse. Now I know people complain about paying a couple $1,000s for a recruiter and getting somebody on, but if you think about the cost of the turnover, and I think that that's even rising because there's many more expenses that we now have with turnover of nurses. We have laptops that have to be returned. We have technology issues. We have a lot of different things that we are concerned about when we do turn over staff. So that's really something you need to evaluate. So having your staff have a solid orientation, an ongoing training program, and make them feel secure. When you're out in the home all by yourself, as you are with hospice and home care, that's a really frightening feeling. When you walk into the home and you find something that you didn't expect to find, which happens quite often, it's frightening. And many times that's the reason for losing those staff members. So as long as they have a proper orientation and then that ongoing training that's necessary in both of these entities, you're probably going to see less of a turnover. And I'm really excited with some of the agencies I talk to, and they say, oh, they've had staff there for 12 and 15 years. I think, wow, God bless you. This is, that's not typical for most of the home care agencies that I talk with, but there are some of those that are still out there and they're still hanging on to their staff for a very long time. The next slide, please. So these are just some projections about the workers are going to be needed by 2024. And you can see nursing stands way out there. And again, it's because of all of those things that we just went over with the retirement, with the increase in the number of patients that we have to see. You can also, you also got to believe that after this COVID scare and all of the news that's been published about patients and patients getting COVID while they're in the hospital, if they don't have it when they go in, they probably have it before they come out. Being lonely, I just was talking to a friend of mine who was in ICU for 2 weeks. She had nobody was able to come to see her. They completely locked everybody out. And she was she was a younger, well, in her 50s, she was young, and in a very frightening situation. And she had absolutely no one coming in to see her. So I think that the idea of healthcare at home is going to expand significantly. I think it has already in this past year. I mean, it's been kind of forced on us, but we have the number of, I'm sorry, I was just reading something. We have the number of patients, again, that do not want to go in the hospital. We actually see that with a decrease in readmissions. If you look at some of the statistics in Homecare Compare, you're going to see that there is a reduction of readmissions to the hospital. So I believe that this COVID scare that we had come up actually has increased the possibilities for home care and hospice. And of course, the hospital's hospital at home program, now that's a waiver. But I do believe that at some point, CMS is going to look at that and say, hey, that worked really well, and we're going to continue with this. It's no longer going to be a waiver. It's going to be part of the program. So keep your eyes out on that and look for opportunities for yourself in working with that. So the next slide, please. So the agency's productivity, again, we're not computers, and we have to look for the ways that we can increase productivity in our staff. And as I mentioned, many nurses complain that the life-work balance is really off when you work in home care. And I can understand that. I've done visits. I've gone out and done aid visits. I've done billing in home care. I've done nursing visits. I've done almost everything you can do in home care in the past. And I understand how stressful it is, that driving, the time, making sure that you're ready to go out and do the visit, make sure you have all your equipment with you, that your nursing bag is stocked the way it needs to be for a particular patient. And it is stressful. So productivity, you need to be working on looking at that, but you need to make sure that you're making way for these staff members to have productivity, that they're not so stressed that they have to leave the organization. Next slide, please. Okay, so the increase in workload, so the turnover, and we talked about this quite a bit, are the documentation requirements, of course. Surges in workload, of course, we've had that over the past few months just because of the virus and the driving time. No visit activity. There's quite a bit of time, of course, that nurses spend not doing visit activity, with doing documentation, doing phone calls to physicians and that kind of thing. So anything we can do to help that is really, really important. I've been really working over the past year or so with a number of agencies to talk to them about improving their intake process, because I think that if we do quite a bit of the intake the way we should be doing intake and getting the information we can get for the nurses, we can really improve a lot of this turnover. And I think that agencies that are more willing to work with the staff, and for instance, we could, as an intake person, the intake person can get information about vaccinations. That's something that takes some time for nurses to try to figure out. They've got to call the doctor's office, or they have to call the hospital to find out if that patient had been vaccinated, because most of these patients, not most maybe, but many of these patients that we are working with are patients that don't have good memories. And so they're not going to be able to remember when they had their last immunization. Of course, the pneumonia vaccine has lasted 5 years, and probably many of those patients aren't going to be able to remember what happened 5 years ago. So if they don't have kind of a record at home, that would be a good time to start one for them when we go in to do the start of care admission. But the intake process is so important to get that kind of information. Call the doctors. The intake person could be calling the doctor's office, asking them when their face-to-face was done, make sure it was a qualified face-to-face visit, that it was similar to the diagnosis you're admitting the patient for, and that type of thing. Helping them with drive time. I know AXXESS has, and I know that many of the EMRs have the drive time recorded, and they have maps where you can get the closest drive time to the patient from where you are. So using technology the way it's meant to be is really important. So having the staff members understand that will be really important. Use administrative staff to cover visits. That's been a problem again over this past year. A lot of managers are getting burned out, and I've talked to a lot of agencies that have had administrative staff members who have left because they're going out and trying to do the job of two people. I got an email from a friend of mine who runs an agency, and she said she was not working on burnout mode, and we don't want anybody to be getting to there. It's too costly, but we don't have that many people. We have our industry lacks the expertise that's needed. So anytime you have somebody who has that expertise, you want to hang on to them. Fatigue, personal reasons, fatigue, drive times, work-life balance, as I mentioned before, is really, really important when you look at the whole scheme of things, and making sure that your staff members are not burning out and you're not throwing a lot at them. Again, technology can help you so much. The use of telehealth, and whether you use it a lot or you use it a little, it can really help you help the nurses feel like they're not overworked. They can get a lot of their work done via telecommunications. They can be checking on their patients. There are companies, I know of a couple companies that are actually doing the remote care themselves and then sending it to the nurse when, sending the information to the nurse when it becomes something that needs to be escalated. So those types of programs are out there, and for agency owners, those are some things that you need to be looking at in the future. Okay, next slide, please. Paperwork is lengthy. These are some things that we found with staff members, that the paperwork is just too long. I do know some agencies are still working on paper. I'm really surprised at that sometimes when I see that, but there are agencies that are still doing paper-based documentation. Orientation is inadequate, and we talked about that a little bit already, but I can tell you that that is a huge problem. And many times, and I've been in agencies where the agency is, they're so desperate for help that if a nurse or a therapist walks in, they say, can I have a copy of your license? Have you done home care before? And they say, yes. And they say, we've got the stack of referrals. Can you go out and see them today? That is not a way to send someone out from a home care. Certainly the conditions of participation require that you have people that are trained. Again, just because someone has worked in home care, I don't care if they worked in there for 20 or 30 years, you don't know what kind of training they've had in the past and what kind of bad habits they've set up. And sometimes the newer people and not having to break bad habits are better to hire than some of those that are seasoned and have developed these bad habits. But my point is the orientation is really, really important. The training's poorly structured. Again, agencies will sometimes just train where they think it needs to be done and not listen to their staff as far as where they feel that they need to have more training. The workload is equivalent to 2 full-time jobs. Again, if we do a proper job of training and orientation with our EMRs and have them use that technology the way it was developed to use, the workload isn't going to be, it shouldn't be as great as some of these nurses are finding right now, and that documentation requiring too much time. Again, they're doing the double work. They're going out and seeing the patient. They're taking notes on paper that are not HIPAA compliant, by the way. And they are then going home and doing the documentation in their EMR. And that's where they're finding the 2 job equivalents. So again, our advice to management would be relief of the stress of the field staff. So in doing that, a proper training, orientation, I can't stress that enough. Those are the 2 things that are going to actually help you keep your staff members happy and keep them in place. Next slide, please. So as far as telehealth, avoiding LUPAs. Part of what we found with PDGM is we really have to be careful with lupus. We don't want to get into a situation where we have patients that aren't at home and that type of thing. So we, being able to get in touch with a patient via telehealth, talking with them, explaining to them that someone's going to be coming out. I know we make phone calls, but I can tell you that that visual expressions that someone has over the video and that type of thing, it really goes a long way with patients. And especially now when people are so isolated in many of the states. I happen to be in Florida and we're not at all isolated. And that's wonderful for me. But there are states I know that where people are very isolated and they enjoy that, that interaction that they have with people with the video. So we can avoid lupus in that way, reducing the risk of exposure to viruses. Again, that's another thing that will help you. So if a nurse would typically go out 3 times a week, one of those visits, although they're not billable, one of those visits might be a telehealth visit, which again would reduce the exposure by 30%. So that's one way that we can use telehealth. Avoiding missed visits, as I mentioned to you, same thing with lupus. We can call ahead of time, make sure that they're going to be there, have a face-to-face meeting with them, make sure they're doing okay, and improving your quality results. I can tell you that most of the telehealth programs have reports that they issue on a daily or a weekly basis. And you can use those reports. Those reports aren't altered. It's very concise information. It's not altered. It's not, you don't have to depend on necessarily the ability of the nurse to be hearing a blood pressure properly. That telehealth program is going to actually give that to you. Can we go back to the last slide, please? Okay, sorry. Is going to give that to you and then achieve objective patient outcomes. This is something that CMS is looking at very, very carefully. If you look at Homecare Compare, and I would invite you just to go in there and take a peek around and look at different agencies and see where their patient outcomes are falling, and look at some of the problems that, especially in the area where the patient satisfaction area of Home Health Compare, the outcomes are going to be reflected in there because some of the patients are not happy with what's going on. They don't feel that they've achieved the proper patient outcomes. And so when these, when your CAPS reporters are calling them or emailing them or sending them mail, they're not giving the best evaluation of the organization. So the telehealth program, I can tell you, from my experience, I can see specific results in the improvement in patient outcomes and patient satisfaction. The next slide, please. Okay, so the purpose of telehealth in your agency, it can be all kinds of different things. We're looking at the reduction of cost with PDGM. And again, PDGM, we thought last year in January, PDGM was going to be all we talked about for the entire year of 2020. And of course, we hardly talked about it at all. And we still all survived. So PDGM is one thing. Having telehealth, work with your agency with the PDGM process. For those of you who have had staff members that were going out and doing a lot of visits, and I still see some of that, and I still see agencies that are losing quite a bit of money with staff doing too many visits. The telehealth program can reduce those visits probably by 50% and not affect your lupus status. You can be doing a lot of face-to-face meetings with your patient. You can do teaching using telehealth, all types of different things. We talked about improvement of outcomes. It does reduce rehospitalization. I was talking to one telehealth provider yesterday, actual telehealth provider yesterday, and he was telling me that one hospital-based agency went from 8.2% readmissions down to 5.2, which was a dramatic change. They had started out at 16 point something. I can't remember exactly what that number was, but that was a dramatic change in just the past year. So their telehealth was, the telehealth in that hospital was really working. And that was a home care based, that was a home care agency. Disease management programs, many of the telehealth programs actually have disease management teaching programs built into them. And so the nurse, as far as the burnout of the nurses and nurses getting tired and feeling like they're working 2 jobs, let that telehealth program do the work for you. Have them get on one of the videos, watch the videos. They can ask you questions when you get there, or even do a telehealth, screen visit with them, and they can ask you questions as far as that's concerned. So the disease management reduction, the COVID-19 issue has really promoted the use of telehealth. And as I mentioned earlier, I do believe that at some point, probably over the next 12 to 24 months, we're going to see CMS have a light bulb moment and say, oh, that's really a good idea. I think we should probably pay for that. And as I mentioned earlier, I know that NOC is working very hard to get telehealth paid for. Right now, it's administrative costs for home health. Just look forward to that and know that that's coming. But getting on the front end of this and start working with it and learning how to use it, really doing a really good orientation with your staff as far as telehealth is concerned. As I mentioned before, some agencies buy all these machines and they just sit on the shelf. So you don't want that to happen. You want to be able to use that in the very best way possible, because it will improve your retention of your staff, and it will improve your patient outcomes. Okay, next slide, please. So in doing a SWOT analysis, looking at your strengths, your weaknesses and opportunities, and your threats, I mentioned to you earlier about this hospital at home environment. The hospital at home, I think, is probably going to be one of the areas where you're going to see remote care monitoring being used a lot. So those agencies that have that available right now and can go to the hospital and say, we have remote care monitoring available for your patients right now, your physicians can use it, you're probably going to see more referrals than an agency who does not have the ability to have remote care monitoring. That's just kind of like coming up with in the times and making that you're current in all of the things that you need to use in your agency. Having an EMR is one thing, and I know that hospitals are encouraged when they know that you have an EMR system, you have a point of care system, but having that, looking at that as a threat to you if one agency has it and you don't, that might be something to consider, again, as you're doing your budget. Opportunities are endless here. You can do so many different things with remote care technology and remote care monitoring of your patient. And I often said that's kind of like having a nurse in your pocket when you have that at home. Were my parents alive today, I would be putting remote care monitoring in their home immediately. There are opportunities for agencies to be like a reseller of some of these systems. So that's another opportunity as far as dollars are concerned. Weaknesses within your organization could be considered because you don't have it. But if you're suffering from lack of staff and you've got an administrator going out and doing visits, so you need to consider telehealth as part of your solution there. And then look at your strengths. What are they? Do a SWOT analysis in your agency. You should be doing that with QAPI anyway. So look at technology as a part of that SWOT analysis. Next slide, please. So these are just some things that you need in developing your telehealth program. You do need to have policies, and just to make sure that I don't forget to say this to you, in your plan of care, if you're using telehealth, you do need to have telehealth ordered in your plan of care. You can't just put it in and say telehealth PRN. You have to say what you're going to do with it, how often you're going to use it, and that type of thing. Make sure that, I do know that, and I don't know about other EMR programs, I'm sorry, but I do know that AXXESS has, and maybe there's one other program that has telehealth identified on their visit note, so you can actually see it. So one of the things you don't want to get caught with is accidentally billing a telehealth visit and having someone come in and look at it and be charged with fraud. And that's exactly what would happen if you're using that. There are surveys going on right now. I don't know if any of you have been involved in that, but the surveyors are coming out to do infection control surveys. And one of the first things they ask is, are you using a telehealth program? The other thing they ask is, are you billing for those services? So I think that's pretty interesting that the surveyors are asking those questions. So be very, very careful that you have orders and that your notes that you write, because you do need to write notes when you do these telehealth visits, that you have that clearly identified in your note. You're going to be writing policies for your telehealth program. So make sure you have your policies updated for the program itself and for your accreditation surveys and that kind of thing. You've got separate consents, because now we're doing, for the most part, we're doing a visual. So we're actually seeing these patients, and it's almost like the picture consent that you get, so that you can take pictures of like wounds and that type of thing. So make sure you have a consent for it. The pandemic policy, the telehealth program would be included in that. Your equipment, the type of equipment that you need. There are some telehealth programs that use all kinds of equipment. You can use a laptop, you can actually use your TV if you have it wired that way. You can use a telephone, you can use almost anything technology-wise. So the types of equipment that you're going to have to invest in is one thing. Some of the companies are actually allowing you to lease the equipment. So those are some things that you need to investigate. The type of staff training. As I said, the success of your telehealth program or your remote care program is going to be based on the energy of your staff. So you want to get your staff excited about it and show them ways that they're going to actually be able to save time and effort in using the telehealth program, and then make sure that you've got this budgeted in. As I mentioned before, for home care, we can use it as an administrative cost, which is really great. And the more agencies that show administrative costs in telehealth, more likely CMS is going to move forward and actually reimbursing us for it. And then make sure that your visit notes and your care plan is designed so that we include telehealth in there. And next slide, please. So these are, I'm not going to go in detail with this, but these are just some LUPA thresholds and the cost of LUPAs. I can't really see that graph with our, maybe I can reduce this. Okay, sorry. The LUPA thresholds here could possibly be a cost to you if you're not watching it. So telehealth and virtual visits, again, we can actually increase the number of visits we are doing if need be. We can possibly use more home health aid services if we need to. With this particular model, it just shows home health aides going in there several times, and then skilled nursing only going in there for management and evaluation. And this is management and evaluation is something that is near and dear to my heart, and I just love management and evaluation. But the use of telehealth technology is exceptional use in management and evaluation, because you can get more visits in by seeing the patient and then doing on-site visits less frequently as you typically would for management and evaluation. Next slide, please. Okay, and then this is just the cost of the different services and what kind of revenue you could lose. And I won't go through this in detail, but just to know that you could lose quite a bit of money if you end up doing a LUPA that you're not expected to be doing during these 30-day billing periods. Next slide, please. So these are some areas that you can look at as far as allowable. The waivers have allowed us to do certain things that we typically couldn't do. All of these items here, with the exception of the visits and the plan of care, are going to end when this public health emergency ends. So keep that in mind and make sure that when you're training your staff on some of this, you're letting them know that this isn't like an ongoing thing, that this will end when the public health emergency ends. I would guess that they're going to give us some time to wind down, but this isn't, not all of these things are ongoing. So face-to-face allowable. Now for the physician, yes, the face-to-face is allowable as long as they can see the patient and it's actually a remote care type of visit. It's not just the visit over the telephone. That's different. So that's the only type of face-to-face that's allowed here. And that has to be well documented. The physicians are being paid for that. Hospice as well can do that same two-way audio-visual assessment. Your initial assessment in hospice and home care can be done using telehealth. And that initial assessment is not a billable visit, it's not a start of care assessment, but it's typically the assessment where you provide the patient their Bill of Rights, get their consent signed via technology if you can, and that type of, so that's very limited. So don't confuse the initial assessment in home health and hospice as being a full, like an OASIS assessment in home care. That's not what it is. And you'll see here on this graph that the comprehensive nursing assessment, the OASIS assessment itself, and the integrated assessment is not something that the telehealth provision allows, but in hospice, it is allowed. Visits on the plan of care, we talked about that already. In hospice and home care, you're going to need to make sure that you have documentation for the visits on your plan of care, and you're itemizing exactly what you're going to be doing with that. The visits do not count towards LUPA, absolutely not, and there's no LUPA in hospice. So social workers and bereavement counselors, they can do telephone visits actually. The provision for hospice level of care visits via telephone are allowed. And then the home health aid supervision is now allowed via telehealth. However, that's going to stop with the public health emergency, so be careful with that. Next slide, please. Next slide. Thank you. So the other uses, I'm not going to go through all of these with you, but the homebound status, be very, very careful with this. I hear a lot of agencies saying, well, that my patient's home because they have the possibility of being exposed to COVID when they go out. That's a possibility. I think that over the next 6 months or so, we're going to see a lot of medical reviews where that homebound status is going to be targeted because the excuse we're using for COVID. I don't know how willing they are going to be flexible with that, but just know that that's a possibility. Certifying the need for NPs and PAs in home health is another waiver that we have, but be very, very careful. Make sure you, and I have not, and I should have before I got on here, I didn't check with your state of New Mexico to see if that was allowed or not. But don't just assume because the federal government has given us a waiver on that it's allowed in your state. So make sure that you're checking your state for that. So you can read through these and see some of the items that are covered in some of the waivers that we're working with right now. Next slide, please. So the use of telehealth has surged between the year 2019 and 20. It's increased up by 46%. Again, among just general consumers. It's increased from 11,000 to 1.3 million among beneficiaries between March and April. The telehealth was viewed more favorably by 57% of providers, and 64% were more comfortable in utilizing telehealth and delivering care. So that has been a big hurdle to overcome, again, with actual providers. The hospitals, not so much. And as I said, I was a little surprised that the physicians have adopted this the way they did, but of course they're making money on it. So I don't think that's going to go away. I think that even though that's a waiver for them, I think that's here to stay, and that they're going to be allowed. They've determined what codes actually work, and so they're able to see many more patients using telehealth in a day than they are with patients actually coming into their offices. And there's still a number of offices in a number of states that are still closed. So telehealth is being used a lot by physicians. So CMS has launched 80 new types of telehealth services. Teladoc itself provided 2.2 million visits alone in the first quarter of 2020. So that is phenomenal. That was when, probably during that first quarter is when COVID hit, they started using it right away. So again, they're looking at, CMS is looking at telehealth as being a vital part of what we actually do. And again, it's accelerating that triple aim target that CMS has to improve healthcare. Next slide, please.
And Arlene, this is Lori from the Telehealth Alliance. I just wanted to make you aware of the time. It's about 5 minutes to 11.
Okay.
We don't have any questions, so I assume it's just because you're so thorough. But yeah, if you want to just touch on some more points.
I will. Thank you, Lori. Thank you. Okay, so again, these are just some more graphs to give you some visual on the use of telehealth. Next slide, please. Another graph that you can take a look at. So these are just these are just percentages of people that are used to using some type of technology, and those that haven't. And some of those patients are now using smartphones when they hadn't before. So they've learned to use those. And so it keeps getting better for the ability of patients in the home to be able to use the technology. Next slide, please. Again, these are just telehealth experiences, how they're viewing telehealth experiences that are actually improving quite a bit. Next slide, please. This one you can take a look at. It's just another, this is a screen actually from an AXXESS program that shows some of the loop alerts and that type of thing. So next slide, please. Okay, so just in summary, of some of the public health emergency changes that we've had, they've used some waivers and some of the new rules to expand the healthcare system workforce. And that some of that has been, has included telehealth, increased local hospital and health systems capacity, the hospitals without walls. Pay attention to that. That's going to be a big deal over the next year or two, I believe. So make sure that you pay attention to what's going on with that and look and see. CMS does have a list of those hospitals that have contracted with CMS. And it went from, I was surprised last week, 2 weeks ago, I looked at it and there were only 52 hospitals that had actually applied for the waiver. And Friday last week, there were 80. So it's increasing quite a bit every week. So pay attention to that and make sure that take a look and see if there's hospitals in your area that you might be able to contract with. Again, increased access to telehealth in Medicare itself overall is certainly something for our future. Expanding in place We're going to expand in-place testing, then enhance patients over paperwork is another thing that CMS is, keeps touting. I haven't seen that yet, but it just seems like we keep getting more paperwork, but they do talk about this being a way to improve the amount of paperwork that we're doing. So next slide, please. So this is just, next slide, please. These are just some ideas for you to look at. And again, you're going to get these slides, so you can take a look at the slides, but it just talks about what you can do with telehealth to improve your QAPI results, like vital signs, your disease management. We talked about a lot of these things throughout the session. So we'll go ahead and go to the next slide, please. Again, I just believe that this is the future. There's a seven times increase for demand for telehealth. They've expanded the waiver a couple different times. And so I think that, again, we're going to see over the next 2 years, we're going to see a great expansion of this. Next slide, please. So hospitals, ACOs, they're all looking to decrease their cost, and telehealth is one way they can do that. So it's really important, as I said in the beginning of this, for each one of you agencies, no matter how small you are, even if you have 20 patients, to take a look at some of these programs and don't go to the first one you look at. Make sure you do some research. Talk to some of your friends who are using telehealth already and find out what they're using and what their outcomes are. And if you have questions specifically about telehealth, you're certainly, I think there's the end of this session has my contact information. Contact me, because I've done my own research. And so I have my own opinions on what I think works and what doesn't work, but I'm happy to talk to anybody if they have questions about this. Next slide, please. And another graph to just take a look at this is just something black and white to show you what your revenue loss and LUPA rates are. Next slide, please. So again, just another slide talking about the future of telehealth. And again, I think that it's probably something that we're going to see grow. Probably 20 years ago, we won't be doing very many visits at all. There will always be some patients and some things that we do in home care that we're going to have to do actual visits with, but for the most part, we're probably going to be doing remote care visitation. Next slide, please. So again, these are just some considerations, and we talked about that with your SWAT program. So take a look at all of these and evaluate how the different areas can be improved by the use of telehealth. Again, I think probably one of the most important things in this whole session would be to show you what we can do to retain our staff and keep things going the way they need to go and not burn people out. And telehealth is certainly a way to do that. Next slide, please. So this is just another graphic on your road for success in telehealth, but do look at this as being probably very, very going to be something that's going to be required in the future, not necessarily that whether you want to do it or not. I think that at some point CMS is going to realize that this is the way that of the future, and that we will need to make sure that we're well advised to take a look at telehealth programs and find one that fits us suitably for our home care agency and for our hospice. Thank you so much, everybody, is there one more slide there? Yeah, so again, I'm happy to take any kind of questions. I was really happy to be invited to speak here today, and would be happy for the telephone. Just you can give me a call or email me, and I'll answer any of your questions. And thank you so much for the New Mexico State Association and the Telehealth Alliance for inviting me, and have a good rest of the day.
Thank you, Arlene. Thank you so much for your knowledge and expertise. We truly appreciate home health being part of this telehealth educational series. I think you've really laid out the case as to why and how we are leaders and innovators in this field. Our next session will be a week from today on Wednesday, January 27th. So that's, you see there on the screen, that is about HIPAA. And we'll be having Michael Herrick presenting. And so you can register with the information provided. And more than likely, you're in the list now, so you'll get more information from the New Mexico Telehealth Alliance about their free telehealth series. Any questions for Arlene? You have her email right there. And then of course, Betty is waiting for y'all. I have two screens, so I see her on my other screen. So that link to the Zoom is right there. And if you have any questions about AXXESS, she'll be there until 11:30 Mountain Time. Thank you so much, Lori and Lisa and the whole Telehealth Alliance crew for bringing this webinar to light. And thanks everyone for being here.